Uh, we'll move to another speech by Dr. P.C. Manoria on a very important topic, that is hypertension mediated target organ damage, demystifying the nuances. As you are aware that the hypertension is globally taking the epidemic position, that about 1.3 billion people are suffering from hypertension. So the matter is very important to discuss. And today we are having the renowned cardiologist, Dr. P.C. Manoria, who will give light on this topic to understand the management as well as their pathophysiology of the hypertension. I will request Dr. Manoria, please uh, deliver his talk on hypertension mediated target organ damage.
आवाज नहीं आ रही.
Just I'm going to start. Can you see the slides?
Yeah.
Yeah.
You are looking all slides.
Okay. So for the next 20 minutes or so, I'll be talking on hypertension-mediated organ disease, which is a very common problem across the globe. The last couple of years has witnessed spectacular advances in the field of Hmod, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. In the context of heart, where HFpEF is an important manifestation of heart involvement in hypertension, we now have SGLT2 inhibitors as a class 1 recommendation for all types of HFpEF. In recent past, injectable semaglutide 2.4 milligram has also shown positive results in the obese phenotype of HFpEF. So in times to come, injectable semaglutide is likely to emerge as a heart failure drug for the obese phenotype of HFpEF. HFrEF is uncommon in hypertensive heart disease and develops only in the late stages, more so if the patient has CKD because of fluid retention. These patients may go in HFrEF, and we have the conventional 4 foundational drugs for HFpEF. In the context of CKD, we have 3 revolutionary therapies: the RAS blockers, the SGLT2 inhibitors, and the non-steroidal MRA, finerenone, which slow down the trajectory of CKD and postpone dialysis by 10 to 15 years. In the context of brain for ischemic stroke, lytic therapy is being increasingly utilized in our country, and endovascular therapy is also utilized in special centers. For peripheral arterial disease and also for stroke, we have a new therapy of dual pathway inhibitor, that is aspirin plus rivaroxaban 2.5 milligram BD, and has shown excellent results in the COMPASS trial. Retinopathy obviously is managed by the ophthalmologist. Now, what is very important to recognize and realize is that all of us know hypertension is a silent killer, but the dicta is not widely percolated that target organ involvement in hypertension may also remain asymptomatic for a long time, and therefore periodic assessment of target organ is very, very important in the long run for better management of these patients. And this is a list. You can see you can have cardiac involvement in the form of left ventricular hypertrophy on an ECG or an echo, and you will not have any symptoms. You can have microalbuminuria 30 to 300 milligram per gram and may not have any symptoms, or even CKD with 30 to 60 ml per minute we see that these patients do not have any symptoms. And in the context of vascular disease, pulse pressure more than 60 is an important sign, or ankle brachial index less than 0.9, or the pulse wave velocity, carotid prefemoral is more than 10. This is also an adverse sign, and you can have carotid plaques without any symptoms. And of course, retinopathy may be there even without symptoms. So periodic assessment of target organ is very important in the assessment and management of hypertension. Now, when we are treating hypertension, it is very important to remember that you have not only to treat the office blood pressure, which represents a single snapshot at time with low reproducibility. You have to treat the whole circadian rhythm of blood pressure, which you can assess by ambulatory BP is possible. Otherwise, home blood pressure monitoring can also be done. So we also look at the nocturnal drop in blood pressure, the morning surges, which are very important for development of cardiovascular events, also for the blood pressure variability. The normal dippers also know the blood pressure drops in the night by about 10%. If it does not drop, this is an adverse sign. Now, CKD is very important, and periodic assessment is very, very important in CKD. All of us know CKD, once sets in, is a progressive disease. There's no therapy available across the globe which can reverse CKD to normal. But we have 3 revolutionary therapies. All are guideline-directed therapies. The RAS blockers, which came in 2001 after the IDNT, the renal trial. The SGLT2 inhibitors, which came in existence after the Credence, DAPA CKD, and the AMPA CKD, and the non-steroidal MRA after the Fidelio, Figario, and the Fidelity 2020, 21, and 23. All these 3 therapies slow down the trajectory of CKD and postpone dialysis by 10 to 15 years. And in recent past, we have seen the positive flow trial with injectable semaglutide 1 milligram. And that has also shown positive results. And in times to come, that is also likely to be approved by the guidelines. And then we will have 4 pillars of CKD, the RASI, the SGLT2, the non-steroidal MRAs, and the GLP-1. The most important problem in CKD is that if you are trying to diagnose CKD, you should not only measure the eGFR, but also UACR. If you don't measure UACR, you will not be able to assess the adverse effects of CKD. Suppose your eGFR is 60 to 89, G2. Now, if you don't measure your UACR, you will not be able. Suppose your UACR is 30 to 300, your risk increases. If UACR is 300 and more, your risk further increases. So UACR at any particular level of eGFR further increases the risk, and therefore both are mandatory. But CKD is highly under-recognized. All of us know it's highly under-screened because there's low awareness, inadequate screening, and despite glycemic control and blood pressure control, 30% of patients still get CKD in diabetes. And when we look at some of the studies, this is data from the AD-CKD study, you can see 85% of patients had eGFR assessed during the 15-month period, but only 47 had UACR assessment, which is inappropriate and should not be done. Now, why we are insisting so much on UACR is, now our UACR normal, as you can see, is 0 to 30. Now, if you look at the all-cause mortality or CV mortality, even when the UACR is within the normal range, the hazard ratio is 1.77 or so. So that 0 to 30 also has increased all-cause mortality and CV mortality. You can see the mortality starts rising after 7 or so. This is the baseline hazard ratio 1. So UACR 10 also has increased mortality. So UACR is very important. Once it crosses 30, the all-cause mortality and the CV mortality further rise. On the other hand, if you estimate eGFR, till the eGFR drops to 60, there's no increase in the CV mortality all-cause. Only when the eGFR goes below 60, you can see the mortality starts increasing. So UACR estimation is also very important besides EGFR. And this another is an excellent slide which shows as the level of UACR increases, less than 30 is normal. Still, you can see 29 patients will develop cardiovascular events out of 1,000. But when it goes to 1,000, you can see 82 will develop cardiovascular events. And UACR is a poor predictor for renal outcome. You can see UACR 30, microalbumin, even in the macro, the increase in CKD events is much less. Only when it crosses 1,000, the CKD events increase. So UACR is very important for the cardiologist. And if there's microalbumin, this is a red flag to the cardiologist. They utilize all preventive measures. So cardiovascular disease in CKD develops earlier in the natural history of CKD, and the renal events takes a lot of time only when the UACR crosses 1,000 or EGFR drops to less than 60. And both albuminuria and fibrosis are closely related to adverse prognosis. So the big message is UACR is not only a biomarker and a target for cardiologists and also for the nephrologist to decrease cardiovascular events in CKD. So for several years, we have been chasing BP targets, LDL target, glucose target, anti-proBNP. Time has come. You must also chase the cardiologist and, of course, the nephrologist, UACR. And if your UACR is elevated, the dicta is decrease UACR at least by 30%, and if possible by another 30% after you have achieved the first 30% reduction. This is a guideline-based recommendation. So the biggest problem in CKD is that early stage CKD is often missed, rather commonly missed. And when diagnosed late, the patient gets little benefit of CKD modifying drugs. So if you are trying to diagnose CKD when EGFR drops to 35 or so, the benefits of all the 3 revolutionary drugs will be minimal. It's only when you start these drugs early in the course of CKD, they will postpone your life. So imagine this is an individual, 57 years old, diabetic patients, diabetes diagnosed 10 years ago, HbA1c slightly elevated, 7.4, blood pressure slightly elevated. And when you get his EGFR, you can see it's between 60 to 19, which means it is EGFR is 60, so he's in the G2 stage. But when UACR is done, which is 352, you can see his risk has suddenly increased. So UACR increases the risk at same EGFR also, and therefore it's mandatory to also measure UACR. And the guidelines, of course, recommend at least measure UACR in diabetic at least once in a year, if you have microalbumin twice a year. And if other features are present, you can measure it even more frequently. So next we talk about hypertension and heart. The heart is again a major organ affected by hypertension, being directly exposed to the high blood pressure. And in the cardiovascular system, you can have left ventricular hypertrophy, fibrosis, which are now recently recognized, diastolic dysfunction. HFpEF is very common. HFrEF is uncommon, particularly occurs when you have CKD, and CAD, angina, and acute myocardial infarction. Now, left ventricular hypertrophy in hypertension, the extent of the left ventricular hypertrophy is predominantly related to the duration of hypertension, the level. So longer the duration, more is the blood pressure, more is left ventricular hypertrophy. And LVH initially occurs as a compensatory process and represents an adaptation to increase vascular ventricular wall stress, and is contributed not only by increase in blood pressure, increased sympathetic activity, RAS activity, salt intake, and there's also genetic predisposition. So if you have a left ventricular hypertrophy, there is 2 to 4 times higher risk of developing cardiovascular events, increased risk of stroke, cognitive impairment, AF, ventricular arrhythmia, even sudden cardiac death, diastolic dysfunction, HFpEF, and HFrEF. Regression of left ventricular hypertrophy can be achieved by drugs, and RAS blockers, ACI and ARB are more effective. Regression of left ventricular hypertrophy results in decrease in the cardiovascular events, HF, new onset, AF, and better prognosis. So how do we evaluate a left ventricular hypertrophy? I think all of us are aware of it. ECG, echo, and of late CMR, that is late granular enhancement on an MR is seen to detect fibrosis. So ECG, I think all of us are aware of that if the R in ABL is more than 11, or the ratio, sum of S and V1 and R is V5 or V6 more than 35, it is a left ventricular hypertrophy. Sometimes you have to utilize to non-voltage criteria also, like the ST segment abnormalities, left atrial enlargement, left axis, QRS duration, and interscoid affliction when the diagnosis of left ventricular hypertrophy is not convincing. This is the usual slide showing is left ventricular hypertrophy with strain and left atrial enlargement also, indicating that this is of quite some long-term standing. Now, on occasion, you see that here you can limb leads do not show increased voltage, but precordial leads are showing high voltage. And this phenomena occurs when you have edema in the feed. If you have edema in the feed, the limb lead will not show voltage because of edema. So this must always be remembered when you are treating patients with congestive heart failure. Now, not uncommonly, you have ST changes in patients with left ventricular hypertrophy, and the question arises whether these ST changes are because of hypertension, that is pressure overload, or there's ischemic primary T wave inversion. And there are some features by which you can differentiate. Now, if the J point is depressed, you can see this is J point is depressed, this is LVH with strain. If J point is not depressed, this is ischemic injury. ST segment is downsloping, this is hypertension with left ventricular with strain, whereas horizontal ST segment occurs in ischemic heart disease. T wave inversion is asymmetrical in left ventricular hypertrophy with strain, you can see, whereas it's symmetrical with IHD. Terminal part of T wave overshoots. You can see terminal part of T wave is overshooting the baseline, whereas this not. So there are some features. If you have an ST change on electrocardiogram, you can indirectly assess whether this is only left ventricular hypertrophy with the strain patient that doesn't coronary artery disease, or patient is also having coronary artery disease. Now, ECG is a poor method to assess fibrosis. If there are multiple serrations in the upstroke or downstroke, as you can see here, it is indicator of fibrosis. But fibrosis is best assessed by LG-CMR. Now, these are the criteria for left ventricular hypertrophy. You can see LV mass more than 115 or 95 in females, or LV volume index more than 34 ml per square meters. The left ventricular hypertrophy could be concentric or could be eccentric. Now, if you have an eccentric remodeling, you can see LV wall thickness is increased, cavity size is normal or small, and LV mass is normal. And the relative wall thickness, which is posterior wall thickness multiplied by 2 and divided by left ventricular internal diameter, should be normal value is 0.42. In a concentric hypertrophy, all of us see in day-to-day praxis, the walls are thick, the cavity becomes small, mass is increased, and RVT is increased. Whereas in eccentric hypertrophy, the LV wall thickness is normal, the cavity size is increased, LV mass is increased, and RVT is decreased. This usually happens when patient goes into CKD and fluid overload. What is very important to remember that if you want to assess the survival of a patient of left ventricular hypertrophy, patients with concentric LVH have poor survival compared to patients with eccentric LVH. So if you have a concentric LVH, the prognosis is worse compared to an eccentric. If you have dilatation of a hypertrophied ventricle, has comparatively poor prognosis. Now you can see this is the concentric dilated ventricle, and this is the survival. So worse survival in concentric dilated. If you have an eccentric dilated, the survival is still better than this. So that is also very important. And this is the usual picture we see on an echocardiogram, concentric left ventricular hypertrophy in the late stages of hypertension. To assess the diastolic function, you have to get at least the transmitral Doppler, place the pulse width Doppler between the tips of the mitral leaflet, and you will see E is greater than A. 1.6 is the ratio between A to A. If there is impaired relaxation, A becomes taller than E. This is A and this is E. Normal, you can see E was taller. And if it is restrictive pattern, the E becomes very tall, the A becomes small, and the ratio E to A ratio is more than 2. And if you have facilities for E by E prime ratio, you can also measure it by the tissue Doppler. E by E prime ratio predicts left ventricular end diastole. Less than 8 is normal, more than 15 is abnormal. And this shows a comprehensive echo criteria for HFpEF. You have to have signs and symptoms of heart failure, objective evidence of congestion in the systemic or pulmonary veins. The PNP levels are elevated, PNP more than 35 and more than 125, you are using antipro. Structural heart disease, you have to have a left ventricular hypertrophy, you have to have a left atrial enlargement, and documentation of diastolic dysfunction, either on a pulse Doppler, preferably on a tissue Doppler, E by E prime ratio of more than 15. So the left atrial enlarged, the left atrial volume index is more than 34. These patients have TR also, left ventricular mass is increased, and the right ventricular systolic pressure is 35 or more, and the TR velocity is 28 or so. Now, as we said, fibrosis in hypertension is being recently recognized, and the fibrosis you can see only on an LGE, CMR, magnetic resonance. If fibrosis occurs in the heart, you can see these white dots. If the ventricle is hypertrophied and fibrotic, this is more prone for heart failure and more chances of sudden cardiac death, ventricular arrhythmia. So fibrosis adversely affects not only left ventricular function, it's a risk factor for development of sudden cardiac death. All hypertrophied ventricle, whether it's an HOCM or other cardiomyopathies, we look for scarring on MR to see if the scarring is more chances of sudden cardiac death. If the left atrium undergoes fibrosis, you can see here, suppose the fibrosis is grade 4D, this patient will be more prone for development of atrial fibrillation and thromboembolic evidence. And those who perform radiofrequency ablation for restoring atrial fibrillation to sinus rhythm, the probability of sustaining a sinus rhythm after RFA ablation is remote if you have a grade 3 or grade 5 fibrosis. So the person who is doing radiofrequency ablation always look at the left atrial fibrosis. Angina occurs in hypertensive disease because you have an accentuated atherosclerosis, there's stenosis in the epicardial, or there's microvascular disease, I'll show you, or it may be increased demand because the left ventricular hypertrophy requires more oxygen, the coronaries may be normal, or this will be combination of all these factors. Not uncommonly, we see a strongly positive test in hypertensive patients, the coronary angiogram is done. So young patients, LVH and a positive stress, and this occurs because the oxygen demand of the hypertrophic ventricle is increased. So when this patient is exercised, he may get even an angina effort and ST changes, but they are not because of coronary artery disease, or there is inappropriate rise. The blood pressure suddenly rises during stress, that will put the load on the left ventricle. So hypertension is strongly associated with a false positive exercise test, and presence of hypertension in one of the studies was 17 times elevated risk of false positive results. So when you are doing a stress test, you must be aware of this fact. This is an individual who has a positive stress test. Obviously, you can see what his angiogram was normal. Now, this is the story of a 40 years old male, chest pain on exertion, TMT is positive, classical history of angina. He got an angiogram in another hospital 2 years back. Angiogram was totally normal, but his angina persisted, and the cardiologist asked him to see a psychiatrist, a gastroenterologist. Nothing happened, chest pain continued. He came to us, and his thallium was also normal. So we did an angiogram, and you can see the angiogram is totally normal. What is missed on this angiogram is the dye is taking a lot of time to clear. Normally, you don't see that epicardial artery takes 2 to 3 cycles to clear. And this is a very simple sign of microvascular disease. Because there's microvascular disease, the dye is taking a lot of time to clear from the epicardial disease, and we prescribed anti-angina drugs, and the patient became asymptomatic. What is important to remember that microvascular angina, the thallium is normal. So the cardiologist often thinks test is normal, thallium is normal, angiogram is normal, patient has no angina. This is again, if you want to document microvascular angina, you have to do coronary flow reserve on a PET scan. The normal is 2. If the reading is less than 2, this is of diagnostic of microvascular. Lastly, we are coming to vasculopathy in hypertension, and we try to assess the pulse wave velocity, the CIMT, the ankle brachial index, and of course, retinopathy. The physician should also So when the left ventricle contracts, a pulse is generated which travels along the aorta as a wave, and you can calculate the pulse wave velocity if you know these 2 points and the distance. So this is the normal aorta. You can see when the left ventricle ejects, the blood from the left ventricle goes into the aorta, comes back slowly, slowly, and by the time it reaches, diastole has already started. Now, when it reaches into diastole, it increases the diastolic pressure, so it increases the coronary filling. So this is the normal phenomena, beneficial. Now, imagine a patient who is hypertensive, he has an aortopathy. It means his elastic tissue has been replaced by fibrous tissue. It does not distend. The compliance is decreased. What will happen? When the patient left ventricle ejects, it goes there and comes back very quickly. And when it comes back, systole is already ongoing. And when systole is ongoing, you can see this will increase the central aortic pressure. This will produce increased load on the left ventricle. Patient may undergo left ventricle failure. It will increase the pulsatile strain. Plaque may rupture, no diastolic augmentation, and no increase in the coronary. Rather, the coronary filling is decreased. So aortic stiffness is an important risk factor for development of cardiovascular events. We have several publications, and we also do the pulse wave velocity with the periscope. You can see, you can calculate the pulse wave velocity. Normal is 10. The carotid femoral here is more than 10, or you can calculate the brachial ankle pulse wave velocity. You can measure the ankle brachial index. I'll show you the data. And the ankle brachial index is a test to assess the peripheral arterial disease. If it is 1 to 1.4, normal, but if patient has symptoms, you have to do an exercise ABI. If it is 0.1 to 0.99, less than 99, it is a borderline PAD and exercise ABI is recommended. But if it is less than 0.9, this is a peripheral arterial disease and requires additional testing either via vascular Doppler angiography or whatever you want to do. Now, carotid intima thickness is also being measured, and the average IMT value is 0.8, less than 0.8. If it is more than 1, this is associated with cardiovascular events in respect to age, gender. And abnormal CIMT or brachial pulse wave velocity, say brachial artery, the sensitivity of 91% for diagnosed CKD. Thus, normal value of both CIMT and left brachial artery pulse wave velocity could exclude coronary atherosclerosis with 91% certainty. Abnormality in both the parameters is associated with more chances of atherosclerotic cardiovascular disease. The aortic distensibility is also being measured by MRI these days. And the SPRINT trial also showed there's better survival of individuals when you treat this patient if the pulse wave velocity improves. So there are 2 patients. Once the pulse wave velocity does not improve with treatment, other the pulse wave improvement. So those subset of patients with the pulse wave velocity increases, their survival is better. Brain in hypertension, I think all of us are aware of, it can produce a ischemic stroke. If ischemic stroke is a large vessel, it is TIA or ischemic. If it is a small vessel, more common with diabetic hypertension, you can lecular infarct, and cognitive decline is a very important complication of hypertension. One of the strong reasons why treatment of hypertension should be initiated in early stage. And for atherosclerotic carotid or vertebrovascular disease, you have to see all these history. You can assess these days by MR angiography, carotid and vertebral, or by CT angiography. Retinopathy, of course, again, is very important, and the physician should also look into the fundus, although final task is done by the nephrologist. So the big message is hypertension is a silent killer, all of us know, but target organ may also remain asymptomatic for a lifetime. And this I've already shown you. And that's why we give a mobile number to our patients. You can see the mobile number. Blood pressure 13080 is for systolic and diastolic. 100. Now this we are trying to slash down to 70 because atherosclerosis progression stops. So LDL should be 70, HbA1c, smoking 0. The treatment of hypertension is long-term, it process of years, and therefore special emphasis should be laid on the quality of patient. We must not forget our hypertension, which not only live but also feel weak. So in treating hypertension young, you should avoid drugs which produces sexual dysfunction. We have excellent drugs to treat hypertension. They decrease morbidity and mortality, but it do not decrease the number of hypertension. Therefore, our aim is to stop hypertension, stop hypertension, stop hypertension, and to build a hypertension-free India. And this is only possible with primordial prevention, which means prevention of emergence of risk factors in population which is not yet developed, and data has shown the best target for primordial prevention is the nursery kids. It is seen if they are adopt primordial prevention, they continue to adopt the same lifestyle in the future. So if primordial prevention is present for several decades, then only we will be able to decrease the incidence and prevalence of hypertension. Data from the familial history, data from the voluntary study has shown that primary prevention does work. So thank you very much for your kind attention.